Hi everybody, welcome back to another live episode of Ret Fix and Chill. Y'all love the live episodes, so we're back with it again here at ASRS in Long Beach in 2025. Today I have the great pleasure and honor of introducing our guest speaker, Rajeev Muni. Rajeev, welcome.
Thanks so much, Sarwar. I know we've talked about this for a while, so
Yeah.
I'm glad we can finally do it in Long Beach too.
Yeah, exactly. And actually, just in case you didn't know, Rajeev was actually awarded the President's Young Investigator Award for ASRS this year. So congratulations, buddy.
Thanks so much. Yeah, it was an amazing honor to get that award from the ASRS and have all my family and friends and colleagues there. So yeah, it was very cool.
The rap album is next, Drake.
Yeah, that's
Watch
right.
out, buddy.
Yeah, that's
Watch
right.
out. So as we all know, Rajeev has done so much work. You've done so much work to sort of expand our understanding of retinal detachments, talk a little bit more about the use of pneumatic retinopexies, and so many more people are doing pneumatic retinopexies. And every single time I do any other surgery that's not a pneumatic retinopexy that ends up with low integrity retinal reattachment, I know that your heart skips a beat up in Toronto. You know what I mean?
That's right. There's a lot of low integrity going on in retina, so we're gonna fix that today.
Yeah. Listen, so Rajiv's going to talk a little bit about some of the classic indications for pneumatic retinopexy, and also some more extreme techniques, because this is a technique that we should all continue to be more comfortable with as a tool in our arsenal for retinal detachments. Rajeev, take it away.
Yeah, so I mean, just a little bit of history, I guess. The first person who I think started doing pneumatic retinopexy in some form or another was a guy named Ed Bouldry on the West Coast, and he was doing it to rescue scleral buckles. And Ingrid Kriesig in Europe was also doing sequential gas injections at a time when they didn't have vitrectomy, and you couldn't buckle everything, like a posterior brake or a GRT. You couldn't fix it with a buckle in certain cases, and they had nothing else, so they used gas. And from there, it kind of evolved, and it got to a point where Hilton and Grizzard and Tornambi and then also Dominguez in Europe started doing these studies. And the first study was the pneumatic retinopexy trial, and that's where the original criteria come from. So that's where you have a single break or multiple breaks within 1 clock hour in the superior 8 clock hours. But when you look at it, there's not that many cases that meet those criteria because they didn't allow any other breaks, even in attached retina. And so what we wanted to do in the pivot trial was make this applicable to more cases. So what we did is we included cases like what you see here, where you have breaks in attached retina that you can easily laser before the gas injection.
Sure.
And so when we use those types of cases, when we do the procedure in those types of cases, we see that it applies to about 50% of cases that walk in the door in a tertiary care retina center. So, yeah.
Sure. Yeah. No.
Yeah.
I mean, I've definitely expanded my my utilization. I mean, I've been doing a lot more SF6.
Yeah.
To get a nice big gas bubble, to get that massive expansion.
Yeah.
I mean, especially in a phakic patient.
It can be a little stressful,
especially if you don't have enough liquid vitreous coming
Yes.
forward and you flatten out the anterior chamber, and there's still NLP after like a couple of minutes. It's a little stressful. But oh man, in a pseudophakic patient,
Yeah.
I'm so aggressive with the AC
Yeah.
tap. I'm like, you know what? Flatten it out. We'll do
Yeah.
0.8.
Right. People worry about the IOP and flattening out the AC, and it's a complete non-issue. Even in phakic patients, you see the chamber completely collapsed. And even then, after the bubble injection, you put them face down, and the gas goes back, and any liquefied vitreous will come forward, and you can retap in about 4 or 5 minutes. And even if they're NLP or pulsatile central retinal artery, you can wait it out, and it'll always generally come down. But I like to retap at about 5 minutes. But you mentioned SF6, and that's kind of one of the key pearls. And we'll talk about technique, but if there's 3 things that I think that can change a failure to a success, or that make your success rates go up, it's putting a lot of gas in the eye. So minimum 0.6 cc's. And I like SF6 because it rapidly expands, and we'll talk about why that's important. Number 2, steamrolling is critical because that can attach most of the retina before you even tamponade the break. And then laser I find very helpful over cryo, and it can greatly expand and improve your success rates because you get some adhesion
Right
away.
Yeah.
And that's a big factor because people are not as compliant as you would want, and that's
especially Americans.
Yeah, that's right. I keep hearing about that. That Americans don't position well, and I don't really buy it, to be honest. Like I know some of our friends on these. On our groups are gonna disagree with me, but I think it's all based on the physician, and I think that when you, as a physician, believe that this procedure is gonna work, and the patient can sense that you really need them to be compliant to make it work, it's gonna work. But on the other hand, if you're like, you know what, I'm gonna put this bubble in, it might work, it might not. If it doesn't work, we'll operate on Monday.
Sure.
When you do that, they're going to the shopping mall, they're gonna do anything,
Right.
and then come to the clinic on Monday and expect surgery,
or go to the Coldplay concert.
Exactly. Yeah. Exactly. Yeah. But so I think that if the physician is bought in and you really believe it's going to work, and this is like one of the secret sauces of doing well in pneumatics, you have to fully be 100% bought in that this is going to work, and you have to believe it. And when you start seeing crazy cases and complex cases that you can attach, you feel like you have some skill, and it's you should feel proud of that, and that with a single gas injection and some laser, you fixed a Stickler's 270-degree GRT or whatever you're doing. And
it's interesting, right? So we talked a little bit about the pivot trial and sort of extending this criteria. I remember a couple of years ago, what sort of really pushed me when I was my first year as an attending, I had a patient with a bilateral RD, MAC off in one eye, MAC on in the other eye, asymptomatic in that eye. So I was like, all right, well, we're going to surgery in a week. That's my next OR day in 5 days. But we need to reattach this other retina. But I don't want to be in a position where, you have this big bubble and you're laying flat and, you get this cataract, because unfortunately, you can't always control what happens before the OR. So it was like a temporal break, and I decided, and this is when it was becoming, you were talking a lot about the extended criteria. It was like a sort of, infratemporal break in the sort of MAC off eye. I'm like, we'll do the MAC on later. We'll do a buccal vit for that eye, but for this, let's put in a big SF6 bubble, and then by a week it'll be a significantly smaller bubble, and I don't have to worry about a cataract in that eye. Right. So that was like my gateway into it. So and a lot of the work that you've done has sort of reinforce that. So I do a lot of pneumatics now in my practice. So you're showing here some extended criteria. So this is from the pivot trial.
Yeah. So these are ones that didn't meet the criteria, pivot criteria. So these are what we would call extended criteria cases for us, but that would be very amenable to a pneumatic. So like the first one, you have a infratemporal break. Maybe it goes below 4 o'clock, but it's still going to do very well. And in a case like that, I would tell the patient even before I started that I'm probably going to put a second bubble on day 3 because I'm already planning. You don't want the second bubble to be like, this has failed and I'm doing this now to try something more and then that fails. Instead, I start out by telling them look, this is an extended criteria case. We need a larger bubble. I want it to expand rapidly. I'm going to put a bubble in now and I'm going to supplement it on day 3. If it doesn't work, then we're going to go to surgery by day 4 or 5 or whatever.
So you manage those expectations.
Exactly.
So because we don't want our patients thinking that this is a failure.
Yeah.
But if you manage that expectation, especially when it's an extended criteria,
exactly.
that's a pro tip.
Yeah, and then this the second case here, you see multiple holes all over the place, but the attached ones you would laser first, and then here in a case like this we would steamroll the patient, and probably the superior ones would be attached, and we would laser those first, and then we would put the patient on their side. So you can access all of these breaks. They're all in favorable locations, but there's many of them. So, but in these types of cases with lattice with holes, you'll be surprised they'll attach very quickly. In a case like this, the trouble is that if the fluid goes down to those inferior breaks, so we're going to laser those before the gas injection, and then sometimes we'll even steamroll them on their side so that, we do side position on a decline and then raise their head on the left side there so that the gas will actually make the fluid displace nasally rather than inferiorly where the holes are there. So,
And the steamrolling here I feel like is very important because I feel like we all babysit. I mean, not just for, obviously for buckles as well. But sometimes I have a few pneumatics. I'm just babysitting the fluid. There's obviously no breaks, but that's why steamrolling is important. But I think what you mentioned earlier is like the doctor needs to buy in. But like what I try to do, and I really don't think my patients do as good of a job, is I demonstrate exactly the positioning that they're going to do over the course. I always face down for like 4 hours, especially because if there's like some fish eggs, just to coalesce those bubbles as it starts to expand, and then they are supposed to position their head in order to perform a successful steam roll.
Yeah, exactly. Yeah, so we do 4 hours of face down for fovea on and 6 hours for fovea off, and then we usually raise the head 30 degrees every hour. So, Sarwar, what would you do on this case, the third case here, where there's breaks in multiple quadrants? So independently, each one would be pneumaticable easily, but when you have two quadrants, a few clock hours apart here. What would you ever try a pneumatic in a case like this?
Yeah, definitely. I would 100% pneumatic a case like this. I would basically I would do it a 0.6 or 0.7 SF6 bubble, and in this case, the head tilt can be a little complicated, especially in the beginning when the bubble is smaller.
Yeah.
So I wouldn't worry as much about that. I would basically just have them like face down and then slowly lift up the head. And I tell them, I want you to go from completely face down up to 15 degrees and then slowly lift up. And I show them what I want them to do. And then basically I tell them to sleep upright. And by tomorrow the bubble will be bigger. And then you're usually able on day 2 to 3 to laser all the breaks, and even if the fluid is displaced, if you've already done some of that steam roll, at least the fovea is clear. And if there's, you may pop other breaks if all the fluid doesn't come out of the breaks, but at least you can laser the causative breaks.
Yeah, exactly. I like your strategy because I wouldn't go for one side or the other. I would just go straight up and see what you got on day one. Sometimes on the next day it's all attached, because of the steam roll. Other times you got one side attached and the other side's not attached, or maybe they're both tracking down. So then on day 1 and 2, you see what you have with the steam roll and then adjust the position accordingly. And I don't like to do alternating tilting really. What I would do in this case is I'd get the supratemporal break first because you don't want it to redetach and go into the macula. So I would position for the supratemporal breaks, laser them, and then do the supranasal breaks, laser them. Once everything's lasered, both sides, then I'll alternate, every 4 hours usually. There's some of my mentors used to tell me that it takes more than 4 hours to detach once a break's already attached. So, they felt that 4 hours was an optimal interval. And the other thing is these kind of breaks that are supratemporal and supranasal, people always say, I'm going to tilt. Tilting is very hard to maintain on a neck. If you have to maintain a neck tilt for a week, that's very, very challenging. So it's much easier to lie on your side with a straight, axis essentially. So
or even like a little bit of elevation, or you can like an elevated pillow, 2 pillows, or leaning down as well.
It's all based on where the highest point of the eye is. So whether you tilt or you lie on your side, it's the same thing.
That's a pro tip.
So whatever. Sometimes
the neck thing is huge.
Yeah, because patients who and Ternambi used to talk about this. Sometimes there were these cases where you had supratemporal or supranasal breaks, or certain locations where the patients just had a hard time maintaining position and had a higher failure rate. So I think if we can get creative with the positioning so you can achieve the same goal but have it in a more ergonomic manner, it'll you'll get better compliance.
Especially for like sitting up position. I think that's sitting up on having a pillow behind you on the couch. It's much easier on the patient's neck. Even for face down positioning, I tell patients, I walk into the room and they're like sitting like this, and I'm like, dude, please don't do that. Put your so you have to support your neck, right? Put your head down on the table, because otherwise you're going to have like cervical issues. Exactly. And I think that's one thing that we have to think about as surgeons, because these are common injuries for us, but also for our patients who are doing this positioning.
Yeah, so this is like a classic case, a pivot trial case, superior break, inferior lattice. We'd laser the lattice, and you have a bullous RD superiorly with this kind of radial type of break. And so this is within 1 clock hour, fair game. And, you would just do your standard approach, aim for a 0.3 cc AC tap, 0.6 cc gas bubble. And then here you can see, so, we got fish eggs in this case, which is not really the end of the world. I mean, even here, you say with a kind of gaping break like that, there's a risk that goes subretinal. But the beauty of SF6 is that it expands very quickly, and these bubbles coalesce. So look at 24 hours, the retina's attached, and you just got one extra bubble, but most of it is all coalesced. And the nice thing about SF6 compared to C3F8 is that because you're putting in 0.6 and it expands very quickly, by the time the steamrolling is done, which is 6 hours face down and then 3 hours until you're upright.
Yeah.
That's 8 or 9 hours where the bubble has expanded so much. So by the time it gets to that break, that bubble that you see at 24 hours can't go subretinal anymore, Whereas if you do C3F8, which is going to expand much slower, and if you don't steamroll, I would be worried about subretinal gas, and that, I think some of our colleagues, you've probably remember like people commenting that I would never do it in a case like this because I'm worried about subretinal gas happening. And that's because you're using C3F8, you're not steamrolling, and you're putting a small volume of gas. And these little bubbles, if there's small bubbles, there's not enough surface tension to keep them from going through the break. So, the key is get a big bubble and have most of the retina attached by the time the bubble gets there.
Yeah, I mean, that's a really important point. I think, I always get fish eggs, and I try the normal techniques. I've tried going on to a lower gauge, but I still do 30 gauge needle. But even if you go in, start injecting, retract out, I usually honestly inject at the area of easiest access. Where I do my intravitreal injections, unless there's an obvious break or some sort of weird pathology there, then I inject elsewhere. So I usually inject infratemporally, and I think I actually I usually AC tap before. I know you do the same. I have them face down, assuming can you see my hand? All right, sounds good. Keep your head down for the next 20 minutes. Even in even during those 20 minutes, a lot of those bubbles will coalesce. And I think that makes a huge difference because the higher surface tension and the fact that the volume is a little bit bigger.
So I think that, the one area I might differ slightly with you is I don't like to go infratemporal because I feel that you're guaranteed to get bubbles. So it all depends where the highest point of the eye is. It doesn't really matter if it's supratemporal, supranasal, infratemporal, but wherever you inject has to be the highest point. So I find it easier to go supratemporal or supranasal because I can have them look down, right, down, and left, and I can inject, and the gas will rise to the ever expanding bubble you're forming. And technique is really important for fish eggs, and I think I use a 30 gauge as well with a 3 cc syringe. I go halfway in and then pull back so the tip is barely in the eye, and then you inject. Not too fast, not too slow.
So you don't inject a little bit first and then retract. You go in halfway and then retract pull back to like a quarter.
Yeah, and then you want to go. And if you go super fast, you'll get a lot of turbulence and more bubbles. And if you go really slow, one bubble will come off at a time. And if you go inferiorly and it's not the highest point, then you'll also get multiple fish eggs. So I like to go superior, halfway in, pull back so the tip's barely in, and then inject it like a constant pace.
Sure.
And,
question for you about that. So I think what you mentioned about injecting superiorly is important. I do try to, for me, I try to make the infratemporal part of the eye the highest point. But one thing that I think is interesting is you usually inject, supratemporally, right? What if the break is supratemporally, right? Do you shift the position depending on where the break is?
So if you have a gaping supratemporal break, like if it's lattice with holes or something, I'm not worried. But in a case like this, if it's a gaping supratemporal break, I'll go supranasal or nasal. So you want to avoid the quadrant of a large gaping break.
Sure.
You also, some people say if it's bullous, does that bother you? Not really, because we're injecting through the pars plana, and it's very rare that the retina is
especially
like that. Especially
when they're supine.
Exactly.
The retina kind of settles down, even if it's bullous when you examine them.
Exactly. So, supratemporal, or supranasal I'll go, and I'll kind of adjust based on the location of the break.
Sure, gotcha. And a super cool case. This is sort of classic. and I see like, you did that laser, and I think doing that laser is super important as well. I mean, it's so interesting, when we're doing these procedures in the US, we're like, all right, well, we have to make sure we put this modifier, put this in the node,
Yeah.
so that we get like paid for the work that we do, because if this, it's not always guaranteed in the American healthcare system.
Of course, yeah. I mean, it's interesting. So pneumatics have taken off in certain parts of the world. Like it's picking up in the US, which is great, but it's gone pretty crazy in India, and I've gone over there quite a bit. I've talked to them a lot, and they know about pneumatics from the Hilton era, but it kind of fell out of favor a little bit, and a lot of the young guys were never even trained to do them. And now it's in a place where there's 1 billion people who can't access healthcare, like it's a no-brainer. You know what I mean?
Yeah.
And so they're kind of learning all these tricks and nuances of the procedure, and it's just amazing to see.
Yeah, I love that, especially without OR access, right? I mean,
exactly.
we have OR access.
But the point I was getting at for payment, so in India, everything you pay for everything out of pocket essentially.
Yes.
And they the issue they were having was they felt that if they charge for a pneumatic and it fails, now they have to charge for a vitrectomy. Many patients would not like that. And so, after talking to them, I said, when you're doing a pneumatic, it's actually a lot of work for the surgeon, because you have to be really skilled at exam. You have to do these lasers. You have to inject. You have to see them every day. It's very intensive compared to a 30-minute, 40-minute vitrectomy.
Absolutely.
That's, it's in and out and you're done. So I didn't feel that they needed to reduce the price compared to what they were charging for a vitrectomy. And so my suggestion to them was that charge the same as you would do for a buckle or a vit, and or even a little more, but then when it fails, don't charge them again. So and then if you do the math and you do your own calculation, say 7 out of 10 will work, and 3 will fail, and those 3 will need a vitrectomy, and so you just figure out what you should charge per case, and so it's just a one-time thing, so the patient doesn't feel it's a failure,
especially if it's like like a 45-minute to an hour case, the amount of physician hours that you've already spent most of that during the pneumatic. And if it doesn't work, then you do this additional work. But I mean, from a ethics standpoint, I think I totally agree with that.
And also for the patient, I mean, I would appreciate that as a patient, because I know my surgeon is trying to get me the best outcome possible, not just do what's the fastest and easiest and whatever. So I think that and it totally depends on the patient. So you have a 95-year-old grandmother who's 3 hours away and who can't position or do anything. Just go on and do surgeries, fine. But if you have a 50-year-old engineer or someone our age who's living next door to your clinic, and that little distortion is going to be totally debilitating for us, right? You would do anything not to have that, right?
Absolutely.
So I'll be like, okay, let's try this. If we're in the 80% and I'm going to be super compliant, you're going to be compliant, and we're going to make it work. But if it doesn't, I know we tried, and then we'll move on. So really, you got to choose carefully and see who your patient is, but. In general, as surgeons, our goal is to just maximize outcomes, and it's just I cringe when I see a simple superior RD with a single break, particularly the superior bullous ones. And if you do a vitrectomy in that case, you're almost guaranteed to have quite severe retinal displacement, distortion. There's these folds you can get, all types of things, and yes, the patient's 20-25 and they're attached. But you find out over time that these patients are not happy at all, and in fact, the better their vision is, the worse they complain.
Because they notice it more.
They notice the distortion. If they're 20/80, they're not complaining about anything. So because they get used to having one eye, and
exactly.
So
interesting point. One thing you mentioned is I think how the surgeon presents something to the doctor. I mean, we know this, right? But especially with pneumatics, right? Because a lot of people want to know about the numbers. So it's this is usually 70 to 80%. But if you think a pneumatic can work in a patient, if you convey that confidence, I'm like, look, the range is between 70 and 80%. If I didn't think it was, and I think in your case, it's probably closer to 80. That's what I tell patients, because I wouldn't even suggest it to you if I didn't think it was a good option for you, right? I don't, for example, if it's an inferior break, I'm not doing pneumatic. You know what I mean? Unless whatever device that you're working on to hang patients upside down, you know what I mean? But conveying that confidence, and you can say, you know what, I think we have a good shot, but In the off chance, remember, nothing is 100%. In the, let's say, 20% chance that it doesn't work,
Yeah.
then we have a surgery that can help us, and
Yeah.
we have also saved your vision because we're able to reattach the center of
Yeah.
your vision a little bit faster.
Yeah. I mean, I agree. And, you know, I hate to use the word premium, but I actually feel that, so, you know, in US and Canada and, you know, around the world, some people are trained to do pneumatics and are good at doing pneumatics, and other people don't have that experience, right?
Yeah.
And I actually feel that the skill set required to do a pneumatic probably is a little more than a vitrectomy, because
Yeah.
a vitrectomy is the same thing over and over.
Yeah.
And it's like, you know, you're a technician, you know, you do the same vit, you shave, you mark the brakes, air fluid
Yeah.
exchange, laser. And whereas here, your exam has to be on point. You have to be able to laser through gas. You have to monitor these patients and adjust the positioning. It's more like a piece of art. And
Yes.
so the way I look at it is like, you know, this is like a premium procedure.
Yeah.
And when you're talking to the patient, you know, it's not like, oh, we're going to try this less, you know, subpar procedure. If it doesn't
Yeah.
work, we go. It's more like, you know, I'm going to try to do the least invasive thing that's going to give you the best possible outcome.
Yeah.
We have data to prove that. And, you know, this is a lot of work for me, and it's
Yeah.
going to be more work for you, but you're going to get better results.
Yeah, I
You
love
know-
that you said that about the art, because
Yeah.
whenever I tell patients about like buckles, I'm like, yeah, look,
Yeah.
this is more uncomfortable, and it's actually a lot harder for me.
Yeah.
But the art of it, I think, is
Yeah.
just because, like, yes, I mean, vitrectomy, especially if there's PVR and things like that, can be complicated as
Yeah.
well. And there's art to like vitrectomy as
Yeah.
well. But because of the factors that
Yeah.
you discussed, there's a lot more art to it and a lot more
Yeah,
nuance to
and
it.
same with buckles. Buckles
Yeah.
is the same thing, actually. So I agree with you. Buckles and pneumatics are just so surgeon dependent, right?
Yeah.
Whereas a vitrectomy is more something that is standardized in terms of the way we do it. And
I want to
so-
see AI do a buckle and like a
Yeah,
pneumatic
that's right.
like us. You know what I mean?
Exactly.
Especially a pneumatic like you. You know what I mean?
Exactly.
Like,
For sure.
bring it. You know?
Exactly. So let's see this one. Okay, so what are you doing here? 22-year-old male. This is a little more controversial because no PVD.
Yeah.
Okay, so
Open break.
a significant larger atrophic hole there.
Is there lattice inferiorly?
I can't remember, but let's say that there's some nasal lattice here. Okay,
The hyaloid's on here.
hyaloid's attached.
So,
Yeah.
so I think this case is amenable to a pneumatic.
Yeah.
But lately, what I've been doing for these cases, because I've gotten better at it and I've been working on doing buckles better, I would probably do like a non-drainage, like 5'10", 5'11" segmental
For
here.
sure.
You know,
Yeah.
that's just because I feel like, especially if the hyaloid's on,
Yeah.
because it's fairly successful. But I've also pneumatic cases like this as well.
100%. And so I agree with you that I think the mistake here is to not do a vitrectomy. Like that, to me, doing a vitrectomy would be not a good decision. Doing a buckle or a pneumatic are both reasonable in my view. And, you know, when you look at a buckle versus pneumatic, we have a randomized trial. That was Ternambi's trial that compared head to head. But those were encircling buckles. You know, it was done 20, 30 years ago, maybe a little more. We can do them less invasive a little bit now. So, you know, I don't know what the data would show, but in that case, the pneumatic group did do better from a functional perspective. You know, I think there's a bit of a misconception about the hyaloid and how important that is. You know, I feel that in a case like this, a young patient, he has a few advantages. Number one, super positioner. They can like lie on their side and watch their iPad for
Sure.
like 20 hours in a row and they're not
Sure.
moving. They can binge watch like a whole series of something, you know?
Yeah.
And number two,
Love Island nowadays.
Exactly. And number two, the RPE is going to absorb the fluid very
Super.
quickly, super fast. And number three, the hyaloid, just like the hyaloid helps in a buckle, the hyaloid being attached kind of helps in a pneumatic, because as soon as you put the bubble in and you start blocking the brake, even with the bubble, but there's compressed vitreous against there, it just attaches so quickly. So, you know, this is a week out, I think, but, you know, this would have attached in a day and we laser it. And this is, you know, a kind of detachment with these atrophic holes. We call them regulated detachments. And
Sure.
they will attach very nicely. So you can have a similar case like with dialysis or whatever, where the hyaloid's on, and they actually work amazingly well. And, you know, in the pivot trial, we didn't even differentiate hyaloid status. We don't, in our practice, we don't even we know about the hyaloid status, but it has almost zero impact on our decision to do a pneumatic. It will impact our decision if we're looking at vit versus buckle, obviously. But
sure.
But for pneumatic, we don't care if the hyaloid's attached or not.
Yeah, interesting. It's because of some of the data you presented that I started offering pneumatics to younger patients, because I think the perception is if you inject this bubble in the vitreous, it may cause a premature PVD if the hyaloid is still on, and that's what people are afraid of. Well, one thing that you and many others have talked about is the compressibility of the vitreous. So it doesn't necessarily force that to happen. That's like the first thing. So I've offered it to a lot of younger patients, and they do really well. And I've also used it in failed buckles with a lot of with the hyaloid on, with persistent RD, and pneumatics work great. The other thing that you've been talking a lot about that I feel like I've been using without really sort of understanding what I'm doing is the idea of a regulated detachment. There's so many times I see a patient like this. It's like, all right, well, it's intertemporal break, MAC on, and it's like, all right, well, we got to go to the OR right away. And you look at it and when did you become symptomatic? You could tell this is not like a rapidly progressing process.
Exactly.
So I'm like, I've become obviously MAC on is an emergency. That's we know that, but these patients, realistically speaking, I mean, it's a point of debate, right? Also, there's also medical legal implications, right? So I tell the patients, I'm like, look, I think we should go to surgery soon, whatever we end up doing, right? And say I'm doing a buckle. I say, but I think this is a slowly progressing process. If you notice anything changing, you let me know. We're going to go to the OR that night, But, I think there's no reason, especially if it's a regulated detachment, if you know what you're looking for and the history, that patient can go on your next scheduled OR day.
100%. Regulated RDs, even when they're fovea split, as long as there's no signs of acute on chronic. So sometimes you get a regulated RD that turns dysregulated because there's a sudden PVD or whatever, or more rapid influx of fluid. Then you'll start to see corrugations, and you got to move on. But when you have a fovea split regulated detachment with no corrugations, it's probably been weeks and months that this has been going on. They just noticed it, and you can schedule them a week, even 2 weeks later, whenever you want. You're not going to wait months and months, but whenever you can get them in, and they're going to do very well. So going back to what you said, in regulated RDs, you can wait. And I think the one thing we know you don't want to do is turn a regulated detachment into dysregulated, because if you did a vitrectomy and turned it removed the hyaloid, and what's going to happen in a 22-year-old when you try to take the hyaloid off, it's going to be difficult, and you're going to get breaks, and it's going to be so sticky, and you're not going to be able to shave properly. And now you have breaks with incomplete vitreous removal, and you get the massive PVR, and you get the dysregulated type of PVR, which is intraretinal and pre-retinal, the really bad one. Whereas if a pneumatic or a buckle fails in a case like this, it's no big deal. You haven't lost anything really. So.
Absolutely, that's a great point.
So I've had regulated RDs that have had a failed pneumatic, and I just waited for 14 days for the bubble to go, and now it's like I have a new fresh RD, which is exactly the way it started. And then I go and do my buckle, because I have so much time. You know,
you buy yourself the time. I think that's important, and I'm glad people are talking more about that, because I think it gets nuanced, especially because MAC on RD, you got to go right away, right? But I think using these OCT signs, the corrugations, I think that's really, really helpful.
Sarah, what are you doing here? So the reason I wanted to show you this case is because there's a subretinal band there. And this patient had a tiny little break superiorly with this kind of chronic detachment, but just a single break, no other pathology.
Nothing inferiorly.
But there's this subretinal band.
Yeah, PVR like this in young patients doesn't bother me anymore. I mean, I've pneumatic, pre-retinal, mild pre-retinal fibrosis. I think as long as you close the break, that traction, reattaching the retina can counteract some of that traction. In some patients who are phakic, pseudophakic, didn't want surgery for whatever reason, like surgery meaning buckle or vitrectomy, I would, if that's the only break I find, I think a pneumatic is a great option. The problem, I think, in this case would be the chronic fluid. But honestly, if I'm able to close the break and the fluid is getting better, not trending worse, I think a pneumatic can be very successful here.
I agree. I think it's unlikely that this traction or subretinal band is having any significant impact on the recruitment of fluid with a small little break superiorly. And so people will say, what if you have an inferior star fold and a superior horseshoe tear? No problem, because there's no relationship between the two. So as long as there's no traction on the brake itself, for PVR, it's worth a try. That said, when patients have some PVR, I'm much quicker to convert to a vitrectomy. Like, I'm not necessarily pushing it as far. So if things aren't going well and they started with star folds, I don't want a situation where it's like 10 days later before I'm doing their surgery.
Right.
I want to figure it out in a couple days, 2 days, 3 days max, and see if I can avoid the vitrectomy. But if not, I'll move forward.
Sure.
So yeah, I think the key here was, like, there was no traction on the brake. You see the laser, that band remained just like a buckle would. And here was the OCT that
Nice.
you see. And you see some residual fluid there, but nothing too crazy.
Love it.
Yeah. So here's another example that I want to show you because, people say, well, there's a ton of inferior fluid. This is a pseudophakic RD.
It's guttering.
It's a temporal break, and you see the little marks there, temporal. I think
It's a tiny break, though.
Yeah, but I think we actually lasered in that area because it was very shallow even before we put the bubble in. Sometimes, very rarely I do that if it's very shallow because then it'll be so easy to find the break later.
Yeah.
I'm not advocating like lasering over detached retina, but if it's very shallow, you can
get it in.
Yeah, get
especially,
it in.
And the best part is like especially if you do LIO, you can depress and get a nice apposition, and then when they position there, the adhesion starts.
It
faster.
starts forming. Yeah, exactly. That's a great way. The other little trick is that you can kind of mark the ora serrata where the in the meridian of the break, because some people struggle with finding the break after. So that's another trick if to help.
Yeah, I know. You always talk about that. I always struggle to actually do it. I actually do slit lamp laser.
Okay.
Just to save my neck.
You do your slit lamps your go-to for pneumatics?
For everything.
Really?
Yeah. And honestly, like, it takes a little getting used to to look through the bubble.
Right. Are you in solo practice though, or do you have a fellow or no?
No, I don't have any fellows.
Okay.
Yeah, I'm still in a private practice.
Okay. Got it.
What's interesting is you can look through the bubble.
Yeah.
You have to adjust. Sometimes if it's when you're at the interface between the bubble and vitreous, you may need to tilt the patient's head at the slit lamp, but you can usually see the break very nicely.
You know what? I'm hearing a lot of this from my colleagues in Japan, in Italy. All parts of Europe, they all do slit lamp, even South America, and I'm amazed that they're having success, because to me LIO is just so much more amenable to like variations in the bubble positioning the patient. But I agree with you in general, like from a back perspective, maintaining your that it's, if you can do it, it's great. I started out, like when I was starting to do pneumatics, I was even using a Goldman long time ago. But, but
I can't use a 3-mirror lens. I use a Mainster 165.
So this is a case of a 35-year-old female. She has high myope. She has a nasal break.
It's mad posterior.
Yeah, it's quite posterior. It looks more posterior than it is. And we put a gas bubble in this case, and here you can see there's kind of atrophy nasally, so it's hard to find the break. But you can see here that the retina attaches, and we were able to do the laser. So those are kind of like all these cases I just showed you were the pivot trial cases and that met pivot criteria. So now I want to show you some kind of different, more extended criteria cases. So here's a patient who has a break superiorly, but it's probably like 2 clock hours, 1.5 to 2 clock hours. So does that change anything for you, or?
No, not really. I mean, this is like sometimes you get worried about gaping. This doesn't really look like it's gaping. I'd probably inject 180 away when I'm doing the injection and go face down right away. But I don't think this is the size of break that would make me not do a pneumatic.
Yeah, I agree. I mean, I think this is where it's the art versus the science of medicine. Yes, it's beyond the criteria, but the same concept. It's a bigger break, but a bigger break is advantageous in many cases. And we're going to show some really large breaks, but because just as easy as it is for fluid to get in, it's that easy for fluid to come out when you apply a bubble to it. So here you can see that we at the end when the bubble's gone, you see we lasered. And here's another little trick that I think is something that is will change your success rate by an extra 5 or 10%, is that, in cases, pseudofakes, and even cases like this, we don't just laser around the break. We also laser 1 or 2 clock hours on either side. And we fan the laser out. So you have 2 or 3 rows posteriorly, but anteriorly we have more 4 rows, because if a pneumatic ever fails, it's always from the anterior aspect of the brake where the traction is.
Sense.
And, we know that, particularly in pseudofakes, that we're missing brakes.
Sure.
So people are like, well, you can't see the brakes, so, I don't like doing pneumatics because they're going to fail. But our response is that, we know that we're missing brakes and we take measures to counteract that. So
Sure.
we would, in a case like this, if they were pseudophakic, we'd laser the brake and then there'd be some temporal or infratemporal fluid and we'd put them on their side and then we'd probably laser more even down to like 4 o'clock there.
Sure,
5 o'clock.
sure.
So, you see how here the laser probably goes from 1 to 4.
Sure.
And
instead of just around the brake. No, that's a pro tip.
Yes. And so that's something that will make a big change, because otherwise, you cryoed a single brake and then now you have a new brake and it redetaches, So this is a case,
Nice.
the scary case, lots of lattice degeneration. This is actually an acute on chronic RD, regulated that turned to dysregulated, had lattice kind of all over. So, tell me, what I did, but tell me, like, what would you think about it? Would you not do it? Would you do a buckle? Like,
so in this specific case, there was a little bit of infratemporal fluid.
Yeah.
So I would be a little hesitant to do pneumatic.
Yeah.
I've done pneumatics for temporal, like large atrophic holes like this, and I think it can work really well.
Mm-hmm.
But I think what my go-to for this is actually, I wouldn't even do an encircling band. I would do a temporal, segmental, and then laser everything else.
Yeah.
I mean, you gotta be okay with babysitting the fluid. But my go-to now is doing a segmental buckle. But I think this is totally amenable.
Non-drainage? You do non-drainage?
It depends. It depends on, like, the level of assistance that I have, how safely I can do it,
and how bolus the fluid is.
How bolus the fluid is. I mean, for example, like for me, if at the end of the case, if this is a young patient, with the nice thing about a segmental or like even an encircling band with like one of these extra elements with the posterior kick, the retina is attached at the brakes. If the retina is attached at the brakes, I usually like to drain anterior to the buckle. I'd probably not even drain and would say, and I tell the patient, look, the retina is probably going to be detached tomorrow. Just so this is a process. I expect it to be detached, and a lot of times it's not, because the fluid is, even chronic fluid is reabsorbed. But I have pneumatic cases like this. But in this case, I personally would do a segmental scleral buckle.
Yeah, I would do a pneumatic, but my favorite segmental is 276, and I'll just do it in as few quadrants as possible.
Yeah.
Like in this kind of case, probably. It goes, the detach is almost like 1 to 4, so probably 2 quadrants here. But
the thing is, I wouldn't even like. I've shifted to more minimal treatment.
Yeah.
So like I wouldn't. That's why I don't think in this case. Yeah, there's lattice.
Yeah.
Yeah, they're at risk of breaks, but I don't like the refractive shift.
Yeah.
That's why I would do a segmental and then laser the other areas afterwards.
The one thing I have noticed with segmentals compared to encircling, though, is as I've shifted more to that, I have had the odd patient that complains of diplopia or whatever.
Because it's a huge
piece,
element.
Yeah, and even if you use a sponge, it's fairly bulky, right?
Yeah.
So,
and this would be right underneath the muscle, right? So
Right.
I've had patients say, "Oh, I have a little double vision when I look in this direction."
It gets
does
better
abate.
often.
It does abate, thankfully.
Yeah. So now let's go into some of the crazy cases. Okay,
here we go.
Here we go. All right. So choroidal detachment, chronic RD, 56-year-old female. That's not a
pandemic.
That's not, yeah.
This is during the pandemic.
Yeah, it was. Yep. That's not a melanoma, at least. Okay, so it's a choroidal, and you have a superior break. So
it's like a total RD.
Yeah. High risk of PVR, right? In a case
especially with the choroidal. I mean, these cases are rough too, because there's probably some chronicity there, and like the IOP is probably low, which is why there's a choroidal. I personally, I had a case like this. I've had a couple of cases like this year. I ended up doing buccal vitrectomies for them. And the reason I did buccal vitrectomies, even though some of these patients had superior breaks, is because I was worried about PVR simply because of the chronicity and because of the choroidal. But the nice thing about a choroidal, because I know you did a pneumatic here, because that's your specialty,
right.
Is that you already have hypotony, right? So you could jack up the IOP, and then you do an AC tap, and you could jack it up even more. God, this sounds so like savage.
I know. So this was at 9:30 in the morning. We put the bubble in at 3:30. You see the choroidal going away, and the next day the choroidal's almost gone. The retina's attached. The beauty is like a single bubble is addressing two issues: the choroidal and the retinal detachment with the break. So and here you can see as the bubble goes away, you have a beautiful recovery. But that said, I will tell you that patients who've had choroidals chronic detachments are higher risk for failure. Again, it's the kind of case where I'm not going to sit on it for a long time. Like it's either going well or it's going to surgery, and I don't want to wait another 2 weeks and go in later. So what about this case? So 78-year-old guy, radial break, superior temporal, some of our colleagues are worried about subretinal gas here.
I personally wouldn't worry about subretinal gas here. I've become less concerned about that, especially with the bigger bubble. But I've done pneumatics in cases like this, and I've had them fail. And I think the reason for that actually is because when the brake is posterior, even if you position their head in a certain position, you got to do a little downward tilt, especially if you don't do the second bubble. So in the cases that I've done similar to this, but almost identical to this, where it failed, when I went in for vitrectomy, when it ultimately failed and I needed to go to surgery, I realized that the brake was so posterior that even though they were positioning perfectly, it was not the bubble, the meniscus of the bubble was not covering that posterior aspect of it.
Absolutely. So that's exactly what happened. So look at it. So the next day, you have
exactly the same
bullous inferior RD, and it's, even though I'm covering part of the brake, the fluid is much worse, right? It's now bullous inferior. So, but we know why that is. So what do? We just add another bubble.
Sure.
So we put a second bubble in on that day, and then you can see here, now you got the inferior aspect of the brake covered.
Dude, I double bubbled my case too, man. It still failed.
Oh, okay. Well, fair enough.
So blame me. And blame Sarweezy. It's cool.
All right, for sure. That can definitely happen.
Yeah.
So, okay, here's a case. I know you don't have to pretend you'll do it. I know. So you have brakes all over the place. There's inferior brakes as well here in attached retina. So you see that. So we lasered all of that, and then with one SF6 bubble, we did kind of this marching laser where eventually had to laser almost 7 clock hours, and you kind of did a steam roll, see what you're left with on day one. You lasered the inferior brakes before the bubble, and then as we kind of marched along to the nasal side, we got all of those brakes treated. Single bubble. Wow. Yeah. So here's a 23-year-old female. So this is what we call this a regulated RD as well, infratemporal retinal dialysis. So how are you doing this one? Because this goes down to, let's say, 4:30 or 5 o'clock.
Yeah, I mean, I would do a buckle here. But I am. I mean,
you used to do buckles on these?
Yeah, well, unfortunately now,
today,
my entire my life has been turned upside down.
That's right. No, so dialyses work amazing with it. It's like, how when you do a buckle on a dialysis, it always works. It's almost the same thing with pneumatics. They almost always work because the hyaloid's on. The patient can position super well. Their RP pump's super strong. So it's just amazing. And this is literally the next day.
Wow.
It's attached. We're lasering the whole thing. And I don't even think the bubble has to tamponade the brake fully. I think just putting the bubble, putting them on their side.
Because the vitreous is your third hand that we don't talk about.
Exactly. So the bubble can, even if it's not blocking the inferior aspect of the brake, you got most of the brake covered. You're winning already, and it just attaches.
And the vitreous basically helps push everything, push the brake closed.
Exactly.
In a way.
Exactly. Okay, let's go.
Oh, dude.
Come on.
I'm not pneumatic in this.
Why not though? Why would you not?
I have trust issues, bro.
Okay.
We listen to Drake. Come on,
All right. So,
but tell me, make me more comfortable about doing pneumatic.
So the first thing, the reason I think people wouldn't want to do a pneumatic here is how are they going to tamponade these 5 clock hours?
Yeah.
And the whole point is that you don't have to tamponade the brake. Okay, so all you want to do, why is this retina is folded over? Because there's a large brake, there's fluid kind of wanting to go subretinal, and gravity is kind of making it just go like that. Now, we've talked a lot about how the buoyant force of a bubble is so huge, right? It can steamroll, you can fully attach someone.
Yeah.
So when I'm looking at a case like this, all I tell my fellows or anyone is that if you can get a bubble in the eye and put them face down with the bubble on the attached retina where there's no brake, you're going to win. So this is 15 minutes later.
Wow. 0.6.
Yeah.
SF6.
15 minutes later. So the retina's fully unfolded, mostly attached, and here's 60 minutes. Okay? And there's no way I did any tampon out of the brake, right?
How did you position?
Face down. That's
this
it.
whole time they're face
Yeah.
down. Okay, got it.
They did no side positioning. So the bubble has not come in contact with the brake. All that we're doing is we're putting a very large force on the retina. And so now instead of fluid wanting to come in, it's wanting to go out. And gravity unfolds the GRT with face down. So
simply gravity, right? Because it's
so at
downwards.
day one, attached, and we laser the whole thing. So here...
Did you do side positioning like
yes.
overnight? You
Yeah,
basically
we
had
did.
side.
Yeah, we would have done. So we basically would have done face down for 6 hours.
Yeah.
And then we would have put them on their left side. Here.
Gotcha.
Yeah. So because at 6 hours, they're going to look like this now, right? And so now I'm just trying to support and tampen out as much of the brake as I can.
Gotcha.
But that's not what attached the retina, which is what scares everyone, right? Now we've turned it into a GRT with no RD basically, and we just have to laser like we would any GRT with no RD.
Sure.
So if you're going to laser a GRT that has no detachment, I can guarantee that, I shouldn't say guarantee, but with a bubble, and if you put it on the attached retina, you're going to turn it into a brake that has no detachment. So, so here's another one. Okay, what do you think? And there's another brake down below too. See there's one at 8. There's 2 horseshoe tears at 6 o'clock.
Yeah, I see those tears as well. So in this case, I think the fear that a lot of people have is that there's so much of the RPE already showing, and whether it's compliance, whether it's just comfort, people would be worried about a big subretinal gas bubble here. I think that's the fear.
So subretinal RPE showing risk of PVR. Inferior brakes also, when you have other brakes in addition to the GRT, the success rates are a little lower. But again, like day one, so again, our goal here is to get the bubble on some part of that attached retina in a certain position. So, nasal or, ideally face down.
Right.
And if you got them face down and you're tamponading the macular region, that fold is going to unfold, and there's a force there that's wanting everything to come out of the brake. And so this is just at day one.
Yeah, so in that situation, you would probably inject inferiorly?
I would have gone nasal.
Infranasal?
Yeah, no.
Or straight nasal?
Straight nasal. I would have had the patient looking to the right.
Yeah.
I would have gone nasally here.
Right.
You could even go temporally, actually, but I probably would have gone nasal. I'm left-handed. I think I would have gone nasal.
Got it.
And then when I put the bubble in, so they'd be looking down and to the right. Nasal, you get hopefully a single bubble. And then I would, as I'm lifting them, they're lying down, I'm sitting them up, I'm putting them face down. And then when I keep them face down for a few minutes, then...
Question, you're sitting them up, right? So when you're sitting them up...
First they're lying down. Okay. As they're sitting up, I'm kind of sitting them up and making their head go down at the same time.
Got it. Gotcha.
And the other thing is, because to look in their eye, I have to lift their head up.
Yeah, sure.
So when I do that, I tilt their head to the right so that I'm looking to see that I have a single bubble. So it's a little bit of
I'm laughing because like sometimes I have them face down and I get on the floor and I have a 28 and I'm like,
don't you love that though?
It's like a pro move. I feel really cool when I'm doing that.
That's why pneumatics. It's like a premium procedure. I'm telling you, you're not getting any surgeon on their back.
That's right.
So,
that's right.
Yeah, but so this was the next day, and here you can see it. The nasal aspect of the brake there, you'll see it's still open and was leaking, and we were able to kind of then just march along and do the laser fully here. And the one thing we didn't touch upon a lot is when you do a GRT, you have risks of retinal displacement in the macula. You can have slippage and macular folds, but with pneumatics, it's impossible based on the physiology of how it works. You cannot get slippage. Slippage doesn't occur in pneumatics at all because slippage can only happen when you have fluid that's going from anterior to posterior when you're draining.
Right.
We're not doing any of that. So slippage is a phenomenon of vitrectomy. It cannot happen in pneumatics, and we also don't get the displacement from the stretching of the retina.
Sure.
Yeah.
Super cool.
So
Dude, what a time to be alive. A tour de force.
I know. It's a fun time to... it's interesting. For the first few years, I didn't talk about these types of cases because I feel like if people go out and just try it on anything, they're not going to work.
Right.
But I think that once you have, especially those last cases, it would ideally like have 200-300 cases under your belt.
Sure.
You're like confident, your laser's good, you know how to manage expectations and positioning, and then you like venture into these more complex cases, you know.
Dude, amazing. I feel like, we're all gonna, need to keep these under in our toolkit, pneumatics, buckles, which were for a while going out of fashion. People were saying these are not being taught adequately, but amazing. It may take me a few hundred more cases to get to the GRT.
Yeah, of course.
But dude, thank you so much.
Oh, it's my pleasure.
Like from Toronto's very own, guys.
Yeah. No, it's good to be
we
here.
appreciate you.
Thanks so much.
Like this is an honor. This is a big learning experience. And thank you everybody for tuning in. We're signing out here from Long Beach at ASRS. We'll see you next time.